Welcome, and thank you so much for joining us for this presentation. I am Megan Kelley, and I am an assistant professor in the Department of Nutrition and Health Sciences at the University of Nebraska-Lincoln.
And I am Falah Rashoka, a doctoral student and graduate research assistant at the Department of Nutrition and Health Science at the University of Nebraska-Lincoln.
In this presentation, Falah and I will be sharing with you about the development, implementation, and evaluation of an educational intervention to address unique barriers to healthcare access experienced by the Yezidi community in Lincoln, Nebraska. Our initial plans for the project were thwarted by the COVID-19 pandemic, a challenge I'm sure many of you can relate to. We'll share how we pivoted our approach to meet the needs of the moment and what we learned in the process. By the end of this presentation, you should be able to name the main barriers to healthcare access faced by the Yezidi community in Lincoln, Nebraska, describe challenges to community-based research presented by the COVID-19 pandemic, and summarize steps taken to revise educational strategies to meet the needs of a marginalized community during pandemic conditions.
Lincoln, Nebraska is considered to be the capital of Yezidi refugees in the United States. For those of you who might not know Lincoln, Lincoln is a city of about 300,000 people and the capital of Nebraska, as you can see in the star mentioned on the map. Many Yezidi have chosen Lincoln as a city to live in because of having a large Yezidi community and having environmental factors that they believe is close to what they have in their city in Iraq. A timeline of Yezidi arrival to the Lincoln. The first Yezidi refugees arrived in Lincoln in late 1997 after flying Iraqi authorities who had forced them to go to the war with Iran. In late 1990, many Yazidis were moved to the UN-managed refugee camps in Syria. Around 200 individuals from those refugee camps relocated to the United States and resettled in Lincoln. Moving on, in 2003, when the U.S. entered into the Operation Iraqi Freedom, between 1,500 to 2,500 Yazidi people worked with the U.S. Army as interpreters and cultural advisors, and many of them lost their life. So due to the high risk this job posed to those individuals and their families, the Department of the State issued special immigrant or special immigration visas. which is called SIV program, to Yezidi who worked with the US Army. Between 2008 and 2014, some of the SIV programs or special immigration visas programs holders were allowed to relocate to the United States, and many of whom styled into the Lincoln. After ISIS attacked the Yezidi homeland on August 3, 2014, another wave of Yezidi refugees came to the Lincoln. Unofficial data estimates that during fiscal year from October 2015 to September 2016, 644 Yezidi are styled in Lincoln. According to the U.S. Department of the State, the number of the Yezidi admitted to the United States in next several years after 2014 was as follows. In 2017, 434 Yezidi refugees were admitted to the United States, and most of them restyled in Lincoln. In 2018, 5 individuals were restyled to the United States. In 2019, 20 individuals were restyled to the United States, while in the last year, in 2020, only 1 individual was admitted to the United States and restyled in Lincoln, Nebraska, according to the U.S. Department of the States. Right now, the Yezidi community in Lincoln, Nebraska estimated that between 3,000 to 3,500 Yezidi individuals living in Lincoln, Nebraska. Research on the health system navigation and health disparities about Middle Eastern immigrants and refugees has largely focused on the Arabic immigrants of the Islamic faith. Thus, less is known about the needs of minority groups such as Yezidi, Baha'i, Sabia, Jewish, and Christians of Arabic descent who live as refugees in the United States. Furthermore, due to the unique language they speak and being hard to reach, little is known regarding specific health states trends or challenges and obstacles faced in the healthcare access for Yezidi refugees. As immigrant communities with the recent experience of marginalization, PTSD, trauma, and other problems due to the genocide and ISIS attack on their city, there is a lot of barriers that facing these communities when attempting access to the healthcare services in the United States.
This visual provides an overview of the process we developed to help address this gap in knowledge. We began by establishing a community advisory board to help us learn about needs and priorities related to healthcare barriers in the Yezidi community. Based on our discussions with our advisory board, we identified key themes to focus on for the development, testing, and evaluation of a pilot educational intervention. In the following slides, we will share about this process and about our findings. Our Community Advisory Board consisted of 9 members. 2 members represented the community-based healthcare agencies that provide primary care services, health screenings, outreach, and other services to many in the Yezidi community. 2 members represented agencies that provide resettlement services and educational and social services for refugees and immigrants. 3 prominent Yezidi nonprofits were represented on the advisory board, as well as several health interpreters and community leaders who were not affiliated with any organization. The Community Advisory Board met 3 times to develop the ideas, content, and educational materials for this project. The meetings were held in person, and we followed up with members individually as needed. During the first meeting, we discussed needs and barriers faced by Yezidi refugees to accessing, using, and navigating the healthcare system. Transcripts from the first meeting were analyzed using in vivo qualitative analysis software to identify key themes, which we will discuss in more depth in a moment. These themes were shared with our Community Advisory Board and reviewed at the second meeting. After receiving approval from our advisory board to move forward, we spent a few months developing educational materials based on those themes. We reviewed those materials with the advisory board in a third meeting and received approval to move forward with revising the materials and implementing the project.
Conducting a community needs and priority assessment. Extensive review of the audio recording and transcripts from the Community Advisory Board meeting revealed a number of themes. Themes related to the Yezidi community's needs are listed here. The first theme is knowing where to go when refugees need healthcare services. Refugees are facing difficulty in knowing where to go to receive healthcare services they need. The process of making appointments with primary healthcare providers may take weeks. Additionally, there can be a lot of confusion about health insurance coverage, terms, process, eligibility requirements, and co-payments. These can differ based on the employer and insurer. That results in many refugees being uninsured. Furthermore, using public transportation system is complicated and requires access to the specific app and a good level of English language, which many refugees didn't. Unfortunately, many refugees don't have a car or driver's license, so the inaccessibility of the public transportation leading many refugees to be unable to access healthcare services. We found that many refugees can't get over-the-counter medication, and there can be a confusion about which medication require prescription and which don't, because there is a lot of differences between what they have in their country of origin and what we have here in United States. Many refugees don't realize there are remedies they can purchase without prescription. The complexity of the healthcare system in the U.S. in comparison with the healthcare system in refugee country of origins leads many of refugees to seek healthcare services at emergency department. This finding is in line with the other studies on refugees and marginalized communities concerning difficulty in healthcare system and others. In their country of origin, one can go to the walk-in clinic and receive healthcare services, whereas in the United States, patients require an appointment and also must deal with the language barrier. The language and dialogue barriers was also another theme developed during our meetings with the Community Advisory Board. There is a need for information and education to be presented in the language in which refugees are found. This applies for both written and spoken information, and that will help refugees in accessing processes. Finally, the COVID-19 pandemic hit just as we were developing the educational materials, and there was a need for reliable information to reach to the community. During pandemic, refugees suffered from a lack of knowledge about preventive behaviors and signs and symptoms of COVID-19. Especially at the first several months of pandemic, health information was only available in English language, which many refugees are not able to read or understand. That led them to depend on the other information from sources of their country of origin, which provided misleading and inaccurate information. We also found several themes related to the educational barriers for healthcare providers, including how important for the healthcare provider to know about the Yezidi culture, their language and specific dialect they speak, and their previous experience with trauma. Concerning culture, it is essential for healthcare provider to know about the culture and cultural humility to provide the best services. Furthermore, healthcare providers often don't realize that interpreters who are brought in to assist Yezidi patients speak different dialects of Kurdish language, leading to the miscommunication. The Community Advisory Board established for the purpose of this research stressed that it is critical for the healthcare providers to know about the historical and ongoing trauma experienced due to the attempts at cultural genocide, and to know how to work with the patient with the traumatic problems due to the past experience.
Based on these themes, we developed two sets of educational materials, one for Yezidi community members and one for healthcare providers. By March of 2020, we had developed all of our slides, handouts, activities, and evaluation materials, and we're in the process of scheduling dates and times to conduct our intervention. The week we had those things in place was the week the tide turned in the pandemic. SARS-CoV-2, the virus that causes COVID-19, was making its way through the United States, and it was becoming very apparent that we had to start taking drastic steps to stop it. Events were canceled, classes started moving online, and some people started putting long dormant sewing skills to use to make fabric masks. It was no longer safe to conduct large in-person gatherings, so we spent some time pivoting our approach. Initially, we had planned to conduct in-person group educational sessions for the project. However, we had to revise our approach to adapt to the conditions of the COVID-19 pandemic. We adapted the slides we had developed for in-person community meetings into an educational booklet that could be sent by mail and reviewed by phone. For the healthcare provider training, we converted the slides we had developed for the educational sessions into a training video that could be completed online.
In the third steps of this community health intervention, we developed educational materials that are culturally and linguistically understandable by the community, as you can see in the samples attached from the booklets designed for the Yezidi community in Lincoln, Nebraska. The educational booklets was written in English and Arabic languages, as many Yezidi read Arabic text and translated variables to the Kurmanji language for those who prefer it. It covered the themes we just covered and included learning objective and application activities for each section. We also developed a pre and post test to see if the intervention led to the change in the knowledge levels, attitudes, or intention of the community. While for the healthcare providers, in this intervention, we developed educational materials, as you can see sample of them in these slides, about what healthcare providers should know about communicating with the Yezidi patient and how to work with them when they interact or when Yezidi patient visit healthcare institute. The purpose of this intervention was to educate the healthcare providers about the Yezidi culture, their language, and specific dialects they prefer. Also, there was a particular section about how healthcare providers should work with the patient with trauma experience and provide the best services you can see. In one of these interventions, we showed them differences in different words when you brought up a different interpreter with different dialogues. For example, when the interpreter is speaking Sorani dialect, he gonna use word jagur when referring to the liver if patient said I have liver problem. While in Kurmanji dialogues, it's called milak. So there's a lot of difference between jagur and milak in medical words. As a part of the third step in our research study, pilot testing of educational materials, these charts show the process we followed to pilot test each educational approach. For the Yezidi community participant, the participants were recruited to the project and informed about the study through phone calls. The participant recruited happened through the Yezidi cultural centers that were part of the project, healthcare centers, health department, art, and personal connection. Participants who consented to the study completed a pre-test. Then, after they completed the pre-test, we sent participants the educational booklets by mail. 2 weeks later, participants received a final phone call to review the booklet and complete the post-test and evaluation. The phone call were conducted by Rashoka and myself, who is a Yezidi doctoral student at the University of Nebraska-Lincoln and is fluent in English, Arabic, and Kurmanji. For the healthcare provider training, participants were recruited by the email through their workplace. Each participant received a link in their email to an online survey form. The survey included a pre-test, the educational video, and post-tests. Participants also provided informed consent through the online form.
20 people reviewed the educational handbook and completed the initial and follow-up evaluation phone calls. Among the pilot project participants, half were insured through Medicaid or Medicare, and 35% were uninsured. Participants were evenly divided in terms of self-rated English fluency. A majority of participants reported that their family did not have supplies needed to protect against COVID-19, such as masks, hand sanitizer, and thermometers. The overwhelming majority of participants reported that they faced problems with interpretation whenever they needed healthcare services. Our health system navigation intervention led to improved learning outcomes among Yezidi participants. Before the intervention, 2 out of every 5 participants misidentified a symptom of COVID-19 as not a symptom. After the intervention, 95% of participants correctly identified itchiness as not a symptom of COVID-19. After the intervention, participants felt more comfortable with the idea of calling a healthcare provider directly, more prepared to talk with a healthcare provider about their health needs, and more confident that they could find healthcare when they need it. By the end of the intervention, all participants' expectations about future healthcare seeking strategies moved away from avoidance or reliance on the emergency room to instead taking proactive steps to engage with the healthcare system. Overall impressions of the pilot project were very positive. Of the 20 participants, 90% were very satisfied with the booklet. 85% believed the information provided was very important. 95% found the information to be very understandable. 70% reported they would be able to use the information provided right away. And 100% thought that the booklet was designed well for a Yezidi audience. Regarding future education and outreach, participants were open to mail-based or online methods for physically distant communication. As for our healthcare provider training, 32 healthcare providers from the local public health department completed the pilot project. After the training, correct responses to the estimated number of Yezidis who live in Lincoln increased from 34% to 72%. The proportion of participants who correctly identified the language that Yezidi clients prefer their interpreters to speak increased from 69% to 97%. And after the training, 91% of participants correctly identified the importance of practicing trauma-informed care with Yezidi patients. Among healthcare providers who completed the online training, overall impressions were pretty positive. 75% were very satisfied with the training. 75% thought the information was very helpful. 81% found the information to be very understandable. 97% said they would be able to use the information provided. And 97% thought the online training was designed well for healthcare provider audience. We asked participants in each intervention to share their suggestions for future educational projects. We learned that Yezidi participants were very eager to learn more about many facets of health and wellness, about civic engagement, and as one participant put it, everything. Healthcare provider participants were interested to learn more about the Yezidi community, including more details about their cultural medical beliefs, religious beliefs, and social norms. We turn our attention now to lessons learned from this project. This graphic applies an ecological perspective to visualize the themes from this project and to present recommendations for education, administration, and policy. Themes from our study reveal two important categories of barriers to healthcare: experiential barriers that occur at the individual and community level, which are shown towards the lower side of the graphic, and more structural barriers that persist at the institutional and policy levels, shown more at the upper side of the graphic. Although the barriers identified here are based on a study of Yezidi refugees, they are not unique to only Yezidi refugees. Our recommendations based on these barriers may be valuable for health educators, program planners, and policymakers working with many marginalized communities, especially communities with limited English proficiency. Our first recommendation is to create tailored cultural and health-related educational interventions according to community-identified priorities and communication preferences. While this may not be a novel recommendation for attendees of this conference, in practice, this process is time and labor intensive and can often be overlooked, especially when organizations are working with limited time and resources. Our second recommendation is to develop culture-specific educational programs for healthcare providers. Participants in our study noted that Yezidi language, cultural customs, dietary habits, religious beliefs, and other areas that influence health behavior and healthcare needs are often overlooked. Our third recommendation is to ensure that interpreters align with the linguistic and cultural needs of patients and clients. Yezidi participants in our study noted that most medical interpreters called upon to assist Yezidi patients spoke the Sorani dialect, whereas the majority of Yezidi speak the Kurmanji dialect. Differences in pronunciation and terminology lead to frustration, anxiety, miscommunication, and inaccurate diagnoses. These complications have become especially consequential during the COVID-19 pandemic. Our fourth recommendation is to provide low-stakes opportunities to become familiar with key community resources. In addition to a need for information, there is also a need to build connection and trust. One approach to address this need is cross-sector collaboration by community agencies and other partners to develop informal opportunities for community members to connect and become familiar with the key people, programs, and resources available in the community, so that disadvantaged and marginalized community members know how to access the right resources at the right time. Our fifth recommendation is to facilitate opportunities for connection between cultural groups in the community. Participants noted that most Yezidi refugees grew up in a very social environment, and that feeling culturally isolated from the broader community can be very detrimental, especially for older adults. Participants also reported that experiences of discrimination in the healthcare setting and in the broader community are not uncommon. Facilitated opportunities for connection between the refugee communities and other groups may boost feelings of mutual identification and belonging. Increased access to practical knowledge and cultural insights may improve community members' confidence to interact with the healthcare system and improve their healthcare experiences. Our final recommendation is to evaluate how current practices hinder access and to develop revised policies. In addition to developing educational approaches and creating opportunities for connection, administrators and policymakers must prioritize policy improvement to address the hurdles over which community members have no control. Participants noted several barriers to care that could only be overcome with policy change. Suggestions they provided were to add regular walk-in hours at health clinics, or to increase the minimum eligibility requirements for government-funded health insurance, or to revisit the distribution of public transportation routes as city demographics shift to prioritize service to low-income workers with limited English proficiency.
Existed healthcare barriers and COVID-19. The COVID-19 pandemic has affected all communities in the United States, but its impacts differ from one community to another. Undoubtedly, the vulnerable population are more impacted than others, especially refugees. In Lincoln, many refugees work in the meat packaging plants and factories and live in the neighborhood with higher population density. meaning they are more likely to be exposed to the virus than our aging population. The social conditions imposed by the pandemic have heightened feeling of isolation, and when Yezidi community members receive a diagnosis, they were unlikely to share it with others due to the stigma about the condition. During the early months of the pandemic, healthcare providers stopped providing in-person interpretation, leading to a lot of miscommunication when seeking care among patients with the limited English proficiency. Additionally, language barriers led to the lack of knowledge about COVID-19 facts, known signs and symptoms, where to go for COVID tests, and where to get vaccinated. All of these factors exacerbated already existing healthcare barriers. These strategies should include translating materials to the community preferred language, using preferred communication channels, and trusted health information sources. The need for physical distances should not negate the need for the social connection. Community health programs should make extra efforts at this time to facilitate social connection whatever is possible, especially for marginalized communities. Finally, significance to have affordable and accessible COVID tests, treatment when needed, and health promotion concerning taking vaccines. What lessons we learned from this study? The COVID pandemic impacts refugees more than any other groups because of social determinants of the health. These entitled living in the poor neighborhood, working in the high-risk areas such as meat packaging companies, lack of health insurance, and difficulty accessing to the correct health information they could understand. Also being moved from different culture and having different ideas about country systems led many refugees to reject participation in any study due to the worrying about impact on their legal state or governmental assistance they are receiving. During data collection and application of this study, we learned that many individuals from communities with no formal education face problems getting access to the materials developed for the health promotion purposes. Furthermore, low health literacy and being new to the technology make it very difficult for the seniors to access health educational materials, which that requiring new innovations approach to access such groups. Besides, some participants had never visited health clinics or medical clinics or checked their health state for more than 3 years because of their inability to navigate the healthcare system. Health department and other health organizations may make information available in more than one language for those hard to reach communities, and will need to make a concentrated community informed effort to reach those who have highest need for education and access to the resources. To our knowledge, this intervention was the first of its kind among refugees in Lincoln. Result of our evaluation suggest approach was effective alternative to the traditional educational approach that were made impossible by the pandemic. Through this study, we also learned about community preference for the future educational effort.
We will build on these findings and expand on this work through a 2-year continuation project titled Fostering Resilience Through Education and Connection. With ongoing guidance from our Community Advisory Board, we will expand on the resources developed so far. As was suggested by our study participants, we will establish an online presence for the program as a place to share resources and engage with the community. We know that health literacy is not simply a matter of being able to find and understand information for health. It is also a matter of being able to act on that information. Our main focus for the next phase of this project will be to facilitate social connections that will strengthen the ability to put health information to good use. To do this, we will create opportunities for Yezidi community members to connect with representatives of key community agencies and with non-Yezidi members of the local community. In addition, we will replicate our approach of working closely with our Community Advisory Board to identify new priorities for education, to develop educational materials and methods that are appropriate to the times, and to pilot an intervention in order to increase access to needed resources for community health. We acknowledge with gratitude the financial support of the Community Health Endowment of Lincoln to fund this project. Thank you for your attention to our presentation. Here is a quick review of what we covered. Through a series of meetings with our Community Advisory Board, we learned that some of the main barriers to healthcare access faced by Yezidi community members in Lincoln, Nebraska include knowledge gaps in the areas of knowing where to go for care, how to get health insurance, how to find transportation, how to use over-the-counter medication, intricacies of the healthcare system, and knowledge of COVID-19. In addition to these knowledge gaps, other barriers to healthcare included language and dialect access, differences in cultural norms and expectations, experiences of discrimination, neighborhood and working environments, and detrimental health-related policies. Just as we were ready to implement our intervention to address some of these identified barriers, the COVID-19 pandemic shut things down. Institutions and community organizations began reducing the scope of their operations by limiting their hours, canceling large events, and, where possible, moving their work online. The methods we were relying on to access the community were no longer valid, and we had to pivot our approach to this project. Since our plans for in-person community-based education were no longer an option, we reconsidered how to best access each group. We developed an online-only training for healthcare providers who could reliably be reached through email. For the Yezidi Community Project, we tried to develop an approach that would minimize known barriers. To minimize technology barriers, we developed a phone and mail-based approach to delivery of the intervention. To minimize language barriers, the mailed educational handbook was printed in English and Arabic, then reviewed verbally in Kurmanji by phone call. We were somewhat surprised to receive feedback that an online option would be preferred, and developing an online presence for this program will be a focus of the next stage of the project. Please feel free to contact us with your questions or comments in the discussion feature of the conference platform. We look forward to interacting with you. Thank you so much for watching and listening. You can find us on Twitter at these handles.